Hi everyone. Today we're going to talk about the T-spine. The basics about the vertebrae and spinal curvatures was in the C-spine PowerPoint, so we won't cover that again, but you can look back at that and see exactly what the curvatures are, and I'll mention them here and there. The T-spine has 12 vertebrae. They're increasing in size from the first to the 12th. And 1 through 4 are more similar to the C-spine vertebrae and how they're shaped and how they're formed. And the 10 through 12 are more similar to the L-spine down at the bottom. 5 through 9 have spinous processes that are a little bit different from all the other vertebrae because they not only do they project posteriorly, but they also project inferiorly and overlap on each other down below. So when you see the spinous process on the middle T-spine, the spinous process that you see may be from the vertebrae above. So when you're looking at number 8, you're going to see the spinous process for 8 down below behind 9. So that's something when you're looking at images, you're going to be able to you're going to have to be able to count that and see that. Clearly the spine is in the posterior. We talked about that before. Unlike other vertebral bodies, the thoracic bodies have costal facets that articulate with the ribs, and the transverse process have facets that articulate with the tubercles on the ribs. So the thoracic vertebrae still has the body and vertebral arch like all of the vertebrae do, and you can see all the extra facets that are on the transverse process here and the superior costal facet on the body, superior articular process and facet here. Those are a little different than what you see on other vertebrae in the spine. The facets are called whole facets or demifacets, and I've listed here down below where each facet and which type it is. On the thoracic spine, you can see the zygapophyseal joints only when the body is turned 70 to 75 degrees rotation from the mid-sagittal plane. It's very steep compared to the C-spine and the L-spine, but that's the only way you can see those joints, the way that they're positioned on the vertebrae. The intervertebral foramina are only seen in the true lateral position. And you can see here the pedicles. The pedicle is the most anterior part of the arch where it attaches to the body, and you can see the intervertebral foramina and a really good lateral here, and you can see the intervertebral disc space and the vertebral body. Here are the ribs. You can see how they come off the back, and they need to be superimposed just like when you're doing a lateral chest x-ray. As far as patient prep, it's just like everything else. You need to be sure to take off all their jewelry, any clothing that might get in the way, anything that's printed on a shirt, even though if you're doing a guy and it's just wearing a t-shirt, sometimes any printing on the shirt's going to show up on the images, so you need to be sure to remove everything from the waist up off. And when you give them a gown, just like any time, you've got to give them instructions or you're going to end up with somebody with it open in the front and you're going to see things you don't really want to see. So just be sure that you've got them putting the gown on correctly, everything from the waist up off. Tell them specifically, as usual, where do you put your clothes and where do you wait and when you're going to be back to get them, that sort of thing, so they know and they're comfortable, not unsure about what they're supposed to do. As far as shielding, you're going to shield all patients. There's no reason not to. Everybody can be shielded with this. It won't be in the way of the images. General instructions, you need to explain the procedures to the patient and explain about breathing instructions. Typically, you're going to have the patient hold their breath, but with the lateral view of the T-spine, you're going to use a breathing technique. And that means the purpose of that is to blur the lungs and rib anatomy so that you can see really clearly the vertebral bodies and the intervertebral foramina here. Otherwise, it's very difficult to see through the ribs and get a lot of detail. So you need at least a 2-second exposure with the corresponding MA setting reduced. So you remember the when you increase your time, you have to decrease your MA so that you end up with the same mass, so you get a good exposure. So some digital equipment doesn't do this very well, but at each site, talk to the techs that you're with and find out what they do for breathing instructions on some of those pieces of equipment, because it doesn't always work very well. That you may be limited as to how many seconds you can set your exposure time to. Trauma patients, we'll go through trauma a little bit later in the semester, but typically you're going to move the image receptor and the CR to get the images without moving the patient very much. If you have to do cross-table laterals, then that's what you'll do, but we'll go through that a little bit more later. The views for the T-spine include an AP and a lateral, and sometimes you may need to do a swimmer's view, and very rarely will you be asked to do oblique views for the zygapophyseal joints, sometimes flexion and extension. If you have to do a swimmer's view, they aren't seeing T1, 2, and 3 very well, so you want to be able to, they want to see T1 through 3, and sometimes the shoulders get in the way and it's difficult to see up there. So you might have to do that, but typically it's just an AP and a lateral. As for the AP view, I'm sure that you all remember the anode heel effect. There's a little less radiation that comes from the anode side than the cathode side of the tube. So that works really well for the thinner part of the upper thoracic compared to the thicker part in the lower thoracic. So you can get a more even exposure. They also have wedge filters that you can use that will attenuate some of the beam at the top of the T-spine so that you can not overexpose that but still get a good exposure where it's thicker down toward the diaphragm. So you're going to use 40 inches. Typically you're going to do these lying down. Some places do them upright, just depends on where you are and what their protocol is. But laying down is a little bit easier, I always found. You're going to use a 14 by 17 receptor lengthwise, table bucky, and small focal spot. You're going to center mid-sagittal plane, and you're going to have the patient bend their knees a little bit so that they're a little more comfortable laying on the table. If they're upright, you need to have their body weight equally distributed with both feet. So a good solid standing base so that they're not going to be unsteady. The image receptor is 1.5 to 2 inches above the shoulders so that you make sure you get the whole T-spine on. And then you need to set the central ray perpendicular to T7, which is exactly where you position also for a chest x-ray. So think about that, where you are in relation to where you would normally center for a chest x-ray, and you should be right where you need to be. Halfway between the jugular notch and the xiphoid is about where T7 is, or 3 to 4 inches below the jugular notch is where T7 is. So it just depends on what's easier for you and how you want to look at it. Collimation is 7 by 17. So if you're going to collimate, you need to do half the width of the image receptor. So 7 inches is all you need. You need that collimation to help get better detail on your images. So with this, you'll do, it said expiration in the book. Jeff says suspend. So hold your breath is typically what I do. So talk to your techs and see what they typically do. But in the book, it said expiration. And make sure your patient's straight. This picture, it looks like the patient is a little bit cockeyed. I don't think that, maybe some scoliosis, it's hard to tell, but the patient might be turned a little bit as well. But just try to get them as straight as you can on the table. For the lateral view, when they're lying on the table, you want to have their spine horizontal. So if you look at their back and their spinal column, it should be horizontal, but you know, men have much broader shoulders, and sometimes that's going to give you an angle down from the shoulders to the waist. So you're going to have to angle your tube 10 to 15 degrees cephalad to make sure that you're getting through the intervertebral disc space and that it's perpendicular to that. So just look at your patient. You can elevate the waist and the lower part of the thoracic, but it's typically easier just to angle a little bit toward the head. Once again, you're going to have the central ray at T7. So if you're looking at the back, the inferior angle of the scapula are going to help guide you there. Now you're going to be a little posterior to the mid-coronal plane because your spine is in the back. So if you center right in the middle, that's more like a chest X-ray. So you want to be slightly posterior to the mid-coronal plane to make sure you're getting the T-spine and not just through the lungs. Be sure to bend the patient's knees and bring their legs up toward their stomach. Put their arms straight, elbows forward, put their hands up, sort of like a praying position, just to keep their arms out of the way. You might, when you're doing this, as you do with a lateral chest X-ray, if you roll the patient upper shoulder away from you a little bit, that's going to help superimpose the ribs so that they're nice and straight. Because if you put them straight up, it might, with the divergent rays, it might shoot the posterior ribs not superimposed. So you want to roll them just the tiniest bit forward just to keep those ribs superimposed. So once again, you're 14 by 17 image receptor lengthwise. You're still going to do 7 by 17 collimation, slightly posterior to the mid-coronal plane, and you're going to use a lead shield on the table, you know, those rubber lead shields, and just put it on the table just beyond the light field of your collimation, and that's going to help clean up some of the scatter so that we get a little bit better detail. So a lot of places will use 40 inches. 48 inches improves the image because there's a pretty good distance between the spine and the image receptor. So the OID, object to image distance. So you want to be sure that you get a little bit more distance than 40. But once again, check at your sites and see what they do. Typically, you're going to do a left lateral T-spine. Brings the heart a little bit closer, of course, to the image receptor and makes it stay off of the edge of the spine so you can see through that really well. Okay, perpendicular central ray to the image receptor, unless, like I said, the shoulders are pretty significantly wide and the body is tipping down at an angle. So line up your central ray to the line of the spine. So it may be 5 degrees, it may be 15 degrees. It just depends. Every patient is a little bit different. So as far as evaluating your image on the AP T-spine, you want to see that you've got enough collimation. Don't forget your markers. Where do your markers go? Probably the upper upper part, because the spine are smaller, the vertebrae are smaller at the top than they are at the bottom. So if you want to put it at the top, that might be a good place. It's not ever going to be in the way. All the 12 thoracic vertebrae need to be on the image. All the vertebrae shown with equal contrast and brightness. Sometimes you're going to have to take two, one for the upper and one for the lower, because the difference in the thickness, you know, you'll have somebody with a really thick belly area but not so thick on the top, and you're going to have to maybe compensate for that. Make sure there's